of acute ischemic stroke and
What happened? Got disconnected?
I think maybe I think because of the live streaming, I think it's got.
I think so. I think he has to come back.
You're on mute, Ajinkya. You're on mute.
Yeah. Am I audible, sir, now?
Yeah, definitely.
Yeah. So the objective of this workshop is to showcase unique cases in the management of acute ischemic stroke and gain insights from the moderators and the wisdom shared by our course director. In the previous workshops, we had a pleasure of engaging in very unique and interesting case discussions, and we are looking forward to have a very fruitful discussion today as well. And it is my honor to introduce our faculty for today's session. So let me share my screen. So I first welcome Dr. M. Pradeep sir, who will be our course director for tonight's session. Sir is chief neurologist at UMED Super Speciality Hospital, Palakkad, Kerala. He is a recipient of prestigious National Merit Scholarship and University Merit Scholarship. Sir has been coordinator in India for 2 years of NSRG of the World Federation of Neurology. He has been chairman of Indian Medical Association continuously for 2 years from 2004 and 2006, and of the scientific committee for the Kerala State Conference of the IMA in 2006. Sir has delivered the prestigious Silver Jubilee Oration at Medical College Calicut on the recent advances in the management of stroke. He has also delivered a lecture on the occasion of annual conference of the International Medical Sciences Academy, which was organized by the Royal College of Physicians, Edinburgh. And he also got an appreciation from the president of the RCPE for the same. Sir has been involved in the research project on the stroke at the National University of Singapore in 2015 and has original research work on tenecteplase in AIS and also a principal investigator for tenecteplase in stroke trial which was conducted in India. He has been a national and international faculty for multiple scientific meetings and conferences and won many awards like Doctor of Excellence Award by Padma Shri Dr. G. Bhaktawal sir, Best Doctor Award by Giants International, and also a state award for the best chairman of the IMA. Sir has more than 15 publications in various national as well as international journals. Welcome, sir. Welcome for tonight's session. Then I welcome our moderator, first moderator for tonight's session, Dr. Anshu Rodgi sir. Sir is consultant neurologist at Sir Gangaram Hospital, New Delhi, and professor of neurology at Gangaram Institute of Postgraduate Medicine and Research. Sir has been a secretary of Delhi Neurological Association from 2021 and onwards. He is a joint secretary of Association of Neurologists in Clinical Research, Mumbai, and coordinator for National Accreditation Board for Hospitals and International Organization for Standardization for Neurology. Sir has been principal investigator in more than 24 studies like VitaTop, Profess, etc. He has over 47 publications in various reputed national and international journals. Sir has presented more than 25 scientific papers at various conferences and has been a guest faculty at many prestigious neurological meetings and conferences. Welcome again, sir. Welcome for No Thrombosis.
Thank you, Ajit.
Then I welcome our second moderator for tonight's session, Dr. Jayanta Roy, sir. Sir is a director of stroke program and senior consultant at Department of Neurology, Institute of Neurosciences, Kolkata. Sir is a certified neurosonologist accredited by American Society of Neuroimaging in 2005. He is a recipient of 2005 American Society of Neuroimaging William M. McKinney Award for the best manuscript based on the clinical research in neurosonology. He is an executive committee member of Society of Neurosonology India and has been a member of educational committee of the Joint World Stroke Congress, Hyderabad. Sir has over 36 publications in various reputed national and international journals and has been a editor of the various neurology books. Sir has been a guest faculty as well at many prestigious national and international neurological meeting and conferences as well. Welcome, sir.
Thank you very much.
Then I welcome our first expert speaker for today's no thrombosis workshop, Dr. Vinit Banga, sir. Sir is a associate director and neurology at neurology and head of neurovascular intervention at BLK Max Super Specialty Hospital, New Delhi. And he has received a World Stroke Organization Young Strokes Professional Scholarship and the award for the best poster at the IronCon in 2018 in Raipur. Sir has won SNVCon 2017 quiz and also won a gold medal in MD Internal Medicine. Sir has memberships of Indian Stroke Association, WFITN, Delhi Medical Council, Indian Academy of Neurology, and he has participated in 14 CMEs and conferences. Sir has multiple posters and paper presentations at various conferences and also has done multiple publications. Welcome, sir. Then I welcome our second expert speaker for tonight's session, Dr. Swaleha Nadab ma'am. She is an assistant professor in neurology at Topiwala National Medical College and Nair Hospital, Mumbai. She has total 10 years of teaching experience and has been a part of 5 clinical trials. Ma'am has more than 10 publications in national and international journals and has won multiple awards like Best Paper in Neurology Award at Bombay Neurosciences Association in 2016, 17 and 18. Ma'am has 5 paper and poster presentations at various conferences as well. The skills and trainings are as follows: stroke management, intracranial bleeds, acute transverse myelitis, electroencephalogram, electromyography, nerve conduction studies, somatosensory evoked potential, botulinum toxin injections, and occipital nerve blocks. Welcome, ma'am. So with this introduction, I would like to hand over this session to our course director, Dr. M. Pradeep sir, for his opening comments and the context setting. Sir, over to you, sir.
Good evening, everybody. Good evening, Dr. Ajinkya. Good evening, the Emcure group, for organizing such a wonderful meeting. You know that knowing thrombosis is very, very important for all neurologists who practice stroke medicine. Stroke management, as you are all aware, is a very interesting field which has evolved considerably during the last few years, actually. It was rather a dormant field a couple of years ago, maybe the previous decade. But since the advent of newer molecules, newer methodology of stroke management, acute ischemic stroke management especially, the management strategy has changed considerably because of the extensive research work which has gone into it, both medicine-wise as well as the gadget-wise, which can remove the clot. So in this context, we have 2 excellent speakers today, Dr. Vinit Banga and Dr. Swaleha Nadab, who will be presenting the interesting cases on acute stroke. And 2 excellent moderators we have, both are great friends of mine. And we are going to have a very interesting, excellent academic feast. Over to the moderators for continuing the session.
Dr. Pradeep, thank you very much for setting the stage. As usual, good to see you again.
Yeah.
We are now waiting to hear from our 2 young colleagues. And I think Dr. Banga will be the first presenter, right?
No, sir. He will be joining in a few minutes. We can start with Dr. Swaleha, ma'am.
Okay. So can I invite Dr. Swaleha, please?
Good evening, everybody. Today, is it visible?
Yeah, it is.
Your video is not visible, Dr. Swaleha.
Yes, sir.
You are not visible.
1 minute, sir. But is the slide is being seen?
Now the slide is also gone off. Yeah.
Okay, okay.
Now it's on.
So, yeah. Can you go to the first slide? Yeah.
Yeah. Good evening, everybody. So I'll be discussing a short case. Patient was 19-year-old male. He presented with history of recurrent episodes of right-sided tingling numbness and weakness. So 19-year-old male presented with history of recurrent episodes of right-sided tingling numbness and weakness of the right side. And he also complained of episodes of slurring of speech. This was going on for almost 4 or 5 days. He got almost 7 to 8 episodes of right-sided tingling and numbness, which lasted for 5 to 10 minutes and recovered completely. After that, he developed right-sided numbness and right-sided weakness, grip weakness. After 3 to 4 episodes of this TIA. And during that time, he also developed slurring of speech. So he was describing the tingling like it started from the toes of the right leg, and then it extended up slowly on the right half of body, and then it went up to the right side of right arm, and then right half of face. And along with that, he started developing slurring of speech.
और कहाँ से चालू होता था, कहाँ पे रहता था? पैर से चालू होता था और ऊपर जाता था और 5 मिनट रह गए खत्म हो जाता। जब कमजोरी का मतलब हाथ उठ ही नहीं रहा था, या मुंह टेढ़ा हो गया था, बात करने को नहीं आ रहा था, ऐसा कुछ नहीं था। ओके, कितने बार ऐसे बार टिंगलिंग हुआ है? 2-3 बार हुआ था। और हमेशा कितने टाइम के लिए रुका था? मतलब वही 5 मिनट।
Actually, I'm not able to move to the next slide.
You can try pressing the page down button, ma'am. Page down or the right click mouse and next slide.
No, it's not happening.
Go to ESC and come out from the full screen mode.
Yeah, I'm trying that only. It's not happening.
Looks like it's frozen. Yeah, I think it's back now.
Ma'am, you can try from the next slide from of that video.
1 minute. It's frozen again.
You can present in this mode, ma'am, as well. You just share your screen.
1 minute.
Okay.
Is it seen?
Not yet.
Not yet.
Oh. 1 minute.
Ma'am, do you need any assistance?
No. I am able to
Oh.
go ahead. Yeah.
Okay.
So is it visible?
Yes.
Yeah.
Yeah, it's
So I'll show in this format only, I think.
yes.
So this was his MRI. It showed left parietal, high parietal infarct. Then there was one in the thalamus also. And then there was one in the posterior limb of internal capsule. These 3 locations were there, which were correlating. Actually, parietal infarct was correlating with his right upper limb and lower limb tingling numbness. And there was a little bit of imbalance of the right side. So that was also correlating with the location of the stroke. And these lesions were restricting on diffusion. I'll just show the angiography. This was the MRI angiography, which was normal. This was a repeat scan that I had done, which showed again the enlargement of the previous stroke and nothing new. So there was no history of prior such episodes, no history of smoking or drug abuse, no vaccines or fever, and no cardiac history in the past. So looking at the MRI, these look like multi-territory embolic strokes. So because of which I further investigated the patient and did the 2D echo, and the 2D echo was normal. So then decided to go ahead with the workup for the young stroke, which included HB electrophoresis, ANA, blot, ANCA, APLA profile, ESR, CRP, and other coagulation workup was also negative. But the strokes kept on, they looked like embolic strokes. So patient, we advise the patient to undergo bubble echo, bubble transthoracic echocardiography, and it showed a small PFO. Basically, there was a moderate right to left shunt through the PFO, and length of the PFO was 4 millimeter, and PFO aperture was 0.5 millimeter. So if we apply the Rope score for this patient, there is no background history of hypertension and diabetes, no history of stroke or TIA. No, patient was a non-smoker, and patient had cortical strokes on imaging. And patient was 18-year-old. So if we apply this Rope score, his score goes around 5 plus 1, and then the rest of this. So it goes about 10 Rope score. And Pascal score, if you, Pascal class, there is another one which is a Pascal classification. So if the risk source is very high, if there is a PFO and a straddling thrombus, and if it is high, if there is concomitant PE or DVT and preceding index infarct combined with PFO and atrial septal defect or a large shunt PFO, it's a medium risk if it's a PFO and an ASA or a large shunt PFO. It's a low risk if small shunt PFO without an ASA. And the Rope score, definitely, if it is 0 to 6, it is low, and if it is more than 7, it is high score. So looking at this patient, what should have been done further? That was the question, whether this PFO is actually the causative behind the stroke, or it is just associated incidental finding, or it is just a risk factor. What should have been done, whether the PFO closure should have been attempted. That was the discussion point. The Rope score was high in this patient.
So what did you decide to do?
So I ended up giving antiplatelets. I ended up giving single antiplatelet and took a cardio opinion also, sir. So according to them, the size of the PFO, the morphology of the PFO was too small or not very significant to explain the recurrent, explain the strokes. So according to him, it was not sufficient to cause the stroke. So that's why then it was avoided, and then he's currently on just dual antiplatelets.
Dual antiplatelets. Okay. So, okay. So how is the patient doing now?
He has not done. Now it's been 3 months. He has not got any repeat episode.
Okay. So, but you were not able to find any other source for the
no other source, yes,
no
sir,
other
no.
source. So that means
No,
that
sir.
it was basically happening because of the PFO most likely, because you were able to demonstrate a right to left shunt. Huh?
Yes, sir. There was, and it was a moderate shunt actually. Here, what they have reported is moderate right to left shunt through PFO.
Okay.
And is it associated in resting conditions or only in Valsalva?
That they mentioned that it is present in the resting conditions also. That shunt is there in the resting condition also.
Okay. All right. So why dual antiplatelets? Do they have any advantage over single antiplatelet in PFO when you manage them medically?
Report.
Sir, actually, because there were small repeated episodes, sir. Initially, he was on Ecosprin, and on that he got TIs. He got almost 4 to 5 per day, and then that's why I shifted him to double antiplatelets.
Okay, but once we did not get any vascular disease and or any dissection or anything, so in that case, probably dual antiplatelet is not going to add any advantage over whatever single antiplatelet you choose. So
True, sir.
at least in the long run. So
Yes,
single
sir.
be enough. And regarding the question of closing the PFO, I think this is too small, and the risk overall is also less as per the criteria. So in this case, I would rather continue to manage medically this patient unless the patient still gets repeated events despite medical management. Then I'll decide about closing the PFO. So I will ask opinion from my other colleagues if they.
Dr. Jayendra, you are absolutely right, Dr. Pradeep. Actually, in this particular case, what's another thing which you should do is that you have to do whether there is what is the source of the ambulance. You just detected a PFO. That's all.
Correct.
You just detected. Is there a definite source for the ambulance? You should do a venous study actually in this patient to find out whether there is any thrombus in the pelvic veins or in the veins in the lower leg to cause an embolic phenomenon. So your long-term anticoagulation depends on fundamentally what is the thrombus load, is there a source of emboli. That has to be detected first. Then, of course, you have done I would say, this even though the size of the PFO is small, then why was it causing such recurrent embolic episodes? That means there is some constant source of emboli which is happening there, which has to be detected, and if needed, that has to be tackled also, first and foremost, rather than just concentrating on the small size PFO. We should detect the source of the embolization. What do you say, Jendo?
Yeah, I think so. I think young boy and small PFO, these are not very uncommon finding in a normal population. So very difficult to correlate between the two. And Dr. Saleh has investigated in detail about all other prothrombotic causes as we do see young strokes.
And one more thing I want to tell you. If you look at the MRI picture which he showed, everything was concentrating on one hemisphere.
Right.
Multiple episodes. Why should it happen in a PFO? Why should it happen in a PFO? See, in PFO it can go to either hemisphere actually. Why recurrently going on to the one? If I think we have to study this patient in detail rather than just implicating the PFO alone, because it is localizing to the left. It is localizing to the left hemisphere all the time whenever he's getting this recurrent attack. So there is something much more than the small size PFO which could be responsible for the whole thing.
Right. And I mean, in my practice, in young, when I do not have a good explanation, I always do a DSA just to make sure that through the vascular anatomy in detail and more clear. Though the MR angio quality looks pretty good, but still DSA is probably a very good investigation in investigating young strokes when you do not have a clear explanation from other things. So
very right, very true. Very true.
I think this is. I think Dr. Pradeep, I think everyone. Yeah, very important point. I think because all these infarcts are occurring in only one territory, so I think DSA is definitely warranted.
Actually, sir, we did the DSA. Recently, we did the DSA. So that was also normal. They did not find anything in that, sir. DSA.
Okay, that's good. But I mean, young strokes, dissections are sometimes
very true. Correct. Yeah.
And they do heal. on their own. There is a 2 to 3 months gap, some spontaneous dissections, they do heal. So I think antiplatelet at this moment for this patient, close follow-up. And I think unless there is a recurrence, then we think differently, right?
Maybe a repeat DSA after a couple of months.
Yeah, I mean, yes, that is, or maybe a good quality CT angio sometimes can
Perfect. Perfect. That's right.
avoid another DSA.
Yeah.
I think this is one interesting case.
So we would prefer a single antiplatelet rather than two, I think.
Yes,
That's
sir.
right.
After 3 months,
I think-
actually, I have changed it to now single only, 75 Cusprin only.
Yeah.
He's better. He's not had any fresh episode. So just one slide. The cryptogenic strokes are like 10 to 15% of all ischemic strokes. PFO occurs in 40 to 50% of patients less than 55-year-old with cryptogenic stroke or TIS. One has to distinguish between PFO being a direct toxical embolism or in situ clot formation or because of arrhythmias. So anatomical features are important to predict whether PFO is responsible for the stroke. For example, the size of PFO more than 2 millimeter or larger shunt can be a cause. Smaller shunt are associated with high recurrence, especially if the rope score more than 7 and hypermobile atrial septum. If the PFO's length is more than 8 millimeter, that is also another high risk factor. So higher the rope score, more likely to be that the PFO is pathogenic. And rope score 0 to 3 is 0% probability of pathogenicity, but 20% probability of recurrence. This concept I did not understand, that the rope score 0 to 3 has a pathogenic risk 0%, but the recurrence risk is 20%. That I did not understand. And even the score of 9 to 10 have 88% pathogenic risk, but the recurrence risk is only 2%. And this concept I actually did not, I wanted to ask actually. Why the recurrence rate is high if the rope score is less?
I don't know what they exactly meant, word by word, but look, these are all probability estimates. And in a given patient, it's very difficult to connect between thoughts and whether this is really the cause for this particular stroke. So I think we have to give a judgment on the whole perspective, and we should also.
വല്ലാണ്ടായിട്ട് പറയണ്ട ഫോൺ ഒന്ന് പോയിട്ട് അല്ലാണ്ട് ഇപ്പൊ നമുക്ക് ഒരു പൈസ തിരിച്ചു കൊടുക്കേണ്ടി വരും. പൈസ വാങ്ങിയിട്ടുണ്ട് 400 റുപ്പീസ് ഇടാം, എന്നിട്ട് ഡോക്ടറെ ഇൻഫോം ചെയ്യാം. അത്രയും നോക്കിയത്. ശരി.
So and I hope the homocysteine and other metabolic parameters are normal for this young boy.
Yes sir, all normal, everything normal.
Okay, so I think as we already decided, a single antiplatelet and follow up for the time.
Yes sir.
Okay,
thank you. Yes sir. Okay.
Any other question or points, or should we proceed for the next case?
I think we can move to the next case.
Yeah, I think so.
Yeah. So Dr. Varun has joined, and Dr. Vineet sir also joined. So Dr. Vineet sir.
Dr. Nishant, hi. I'm extremely sorry for the delay. Actually, I've got to be in lab for some emergency. So Dr. Nishant will be presenting on my behalf the case, and he'll begin. And I'll be throughout the case. I'll be there, but he'll be presenting on my behalf.
Okay.
Okay,
sure.
sir. Yeah, Dr. Nishant sir, you can share your screen, sir.
Okay, sir.
Sir, do you need any assistance in sharing the screen?
I think I'm not able to get the file from this app. It is saved on the desktop, but I'm not able to access that.
You can copy paste in the drive if possible. Yeah, it's visible, sir.
Visible?
You can switch to, yeah. You can switch to slideshow mode.
Okay, yeah, sure.
Yes, this one, sir. Yeah.
Something else is coming. Is it visible now?
So yeah, it's visible.
Good evening to everyone. I am Dr. Nishant. On behalf of Vineet sir, I am just presenting this as a rare case of stroke in young and how we came to etiological diagnosis of this case particularly. I'm a DNB resident here. So to begin with the historical part, he's a young male of 45 years of age, educated, working currently in a Delhi police, is right-handed and is a resident of Delhi. He was admitted with chief complaints of recurrent history of right arm weakness, followed by a slurring of speech since past 6 months. During the past 6 months, he had nearly 3 episodes. The first episode, he noticed he was traveling with his friends to Shimla. Then what happened? There was suddenly, while eating food, he had the right arm weakness, and this was associated with slurring of speech. And the event lasted for nearly 5 to 10 minutes, and spontaneously it recovered. But the moment and the arm of weakness in the arm was significant from the historical perspective and to the patient also. Although it recovered, but he was a bit conscious about this fact. The next day he went to doctor for the same thing. Although there was no weakness in any part of the other part of the body apart from that weakness, and there was no loss of consciousness. He was evaluated at outside there only in Shimla itself, and he was found to have a left MC territory infarct, which was very tiny infarct, and he was put on antiplatelet tablet Ecosprin AV 70 or 20 combination was given, and he was subsequently sent home, and he was ultimately fine. Also, he was doing normal routine work. He has already joined duties. Then what happened, nearly the second episode happened after nearly of 2 months of that, and it was all of the same semiology nearly. There was right arm weakness with slurring of speech, and this event also lasted for nearly 5 to 10 minutes. But this episode was associated with subtle confusional state at that moment, and he was transiently not able to communicate with the caretakers, and who were just he was not aware of the surroundings also. And this event also recovered spontaneously. And when he went for this episode to the doctor, he had came back in Delhi, and he went to some other hospital. uh, Anti-epileptics were added to this episode, and this all semiology was thought that it is the seizure etiology which is just pertaining, and he was put on some antiplatelets. He was put on levetiracetam 500, and he was also fine with that. And subsequently what happened, even after taking anti-epileptics, nearly 2 3 months of that, uh, just a prior to the day of admission, he had the same kind of semiology of right arm weakness transiently, and this time also he came to emergency. And at that time, when the MRI was done, it was found to be an acute stroke. It was positive in diffusion as well as it was positive in the flare. It was a non-disabling stroke, and the patient at that time, when he visited the emergency, he had already recovered of that event, and he already took ecosprin when he developed this episode. He also communicated with the previous hospital for the same reason, and he was told that this might be a seizure episode, but ultimately you can come to the hospital and see what can we do for you. Then, when he came to the hospital, it was found to be a stroke rather than a seizure.
Then he was admitted subsequently, and his routine, all the routine was done. And history was reevaluated from the beginning to this nearly 2-3 months landed up during this time, and he had recurrent 3 episodes of all these, and all had nearly same semiology, but the last one was a bit more prolonged as compared to the previous one. Normal CT angiography was done to just find out whether there is some small vessel occlusion, but it was absolutely normal. And as a part of stroke routine workup, after planning a normal baseline investigations, normal echo, Holter, then we subsequently also go for the transesophageal echo. And that also subsequently was normal and found to be there was no intracardiac abnormalities. Atrial fibrillation was also to be ruled out, and Holter was also turned out to be negative. And subsequently, an extended loop recorder was also done for that matter, just to pick up if there was any cardiac atrial fibrillation that was contributing. And vasculitic were ANA profile, ANCA, PNCA, all were sent and all were within normal limit. Then we went to go ahead with the step of DSA. When the DSA was done, there was different images which were taking of the DSA, and it was found that during the arterial phase as well as while during the venous phase, there was a stasis of the blood transiently in the carotid region mainly. As you can see in the first film, during the filling phase, you can see a stagnation of the dye even when the venous phase is just coming out. In the subsequent also, it was found that there was a more prolongation of the stasis of the dye in that part. And in the third image also, it is also obvious that there was a stasis of the dye even in the venous phase. And subsequently, it was found, and the literature was reviewed. We thought that it might be a typical presentation of a carotid web. Carotid web usually is a very rare diagnosis and does not present very often. Oftenly, it is present in most of the cases, but not easy to pick up. Then we went ahead to give anticoagulation to the patient, and patient was put on Eliquis twice daily, and ongoing antiepileptics were stopped. And nearly past 7 months into the illness, he is continuing Eliquis, and there was no subsequent episodes of any of the same hemiparetic event or some clouding or confusion. There was not present. Just to sum up that the gist of the case was that in a young patient, especially if the semiology is a typical localized to a particularly territory, we have to also look out for the vascular causes. And in that cases, the DSA study was suggested as a prolongation of the dye, or there was a more stasis of the dye in the right carotid part. It was diagnosed to have a case of a carotid web, and carotid web usually is treated traditionally with antiplatelets or anticoagulation, but the data perceived is neither beneficial for both of the cases. But anticoagulation is more preferred as there are more chances of the atheroma formation and subsequently leading to the emboli formation. So carotid web is a non-atheromatous, non-dissecting membrane-like strand that protrudes into the lumen of the carotid artery. There is a high risk of stroke recurrence that may be explained by flow stagnation along the superior surface of the septum that leads to the formation of a superimposed thrombus, and ultimately that can lead to cerebral embolization. Carotid web is generally not a common entity, and it is known by different names, and it is not easy to pick up. It is very difficult even to pick up in the CT scans, normal ultrasound. If we do a carotid Doppler, it is often missed. Carotid web-like formations or a carotid pseudovalvular folds, carotid shelves, carotid diaphragm or thrombotic, carotid megabulbs. The prevalence is very under-recognized in case of strokes. In various trials, it has been shown nearly 2.5% of the patient with acute stroke with a large vessel may have a pertaining underlying carotid web as the etiological cause. In a prospective series of young teratogenic stroke, the incidence of recurrent stroke in patients with carotid web was found to be nearly 29%, while in other stages, the percentage may be as high as 74%. Due to carotid web, the recurrent event is most of the time within 12 months of the detection, and carotid web is mostly located in the posterior wall of the carotid bulb. It is hardly detected by ultrasonography, and it may appear similar to atherosclerotic plaque, and it is often missed due to that reason. CT angiography and digital subtraction angiography have been demonstrated to be optimal neuroimaging to identify carotid webs, and in that, too, carotid web is more easily picked, more easy to diagnose in case of DSA rather than a CT angiography. And in DSA also, we have to take different images at different angles just to position and localize the carotid web in a good way. And there are, regarding the treatment, there are no randomized control trial regarding the treatment, whether we should go for antiplatelets, whether we should go for anticoagulation. But as in our case, the patient was already on antiplatelets, but in spite of that, the patient had recurrent episodes of seizures, hemiparesis. And so ultimately we decided to put him on anticoagulation. Although there is also not strong evidence whether we should go for anticoagulation or antiplatelets. Clinical presentation may be in form of recurrent ischemic stroke or recurrent transient ischemic attacks, especially in young patients. And in one study, it was found to be a recurrent case of stroke, maybe as high as 29% may have carotid web as underlying cause. Otherwise, they are mostly asymptomatic and do not cause anything to the patient also. Digital subtraction angiography is considered the gold standard imaging for modality for detecting the carotid webs, whereby most of the carotid contrast is seen to pool in the web, even in the venous phase. Spontaneous it is also known as spontaneous internal carotid artery dissection flap, and dissection is generally more distal along the carotid artery and has more irregular borders and may cause increase in the arterial diameter from leading to formation of pseudoaneurysm or a atherosclerotic plaque, which tend to have more irregular border and may also be distal to the internal carotid bulb and may have to be associated with calcifications. Thank you.
Thank you, Dr. Varun. It's a very interesting case of young stroke. So there are a few points I'd like to make here.
Yes, sir.
First of all, yes, this patient had a recurrent stereotype TIA involving the left MCL territories. And first thing is what you showed in the DSA, this stasis of the dye, and then it clears off. Can it be a dissected flap? I mean, the false lumen when the dye goes in and then out through the dissected flap? Because the reason I'm telling this, as you know, that the carotid webs are basically the scaffolding, and the carotid wall, mostly from the posterior part, a little distant from the bulb, because that is the difference with the atherosclerotic plaques. So usually they are very well visible filling defects if you do proper MIP in the CT angio. I mean, each and every carotid web I have seen, though this is rare, but they are very well picked up in the CT angio. So how the CT angio missed a carotid web which is causing a stroke like this? This is one point is actually surprising me. And the second point is, I mean, as I already told, that this stasis of the dye, and then do you have any DSA picture of that rather than the cine? You have any still picture of DSA of that level and see whether we can see any feeling defect? Can you go a little slow frame by frame and see? It's more like a tapering thing. And if you look at the pictures of carotid web in the image or even the pathological specimen, they are like a scaffold. They protrude at the lumen like a shelf. So this morphology I'm missing in this picture. So I was wondering whether this could be a dissected flap, and the dye is going to the false lumen and getting and then going through another aperture and clearing off. So I will ask my other colleagues also what is their take on this. And this is the third point is carotid web anticoagulation. Of course, this is not a very regular thing we do in carotid web, rather than putting them on antiplatelets. And if a carotid web continues to throw thrombus, despite somebody on antiplatelets, then stenting is another option to treat that, rather than putting them on anticoagulation, because that is not supported by much of the evidence. So I think these are the 3 points I'd like to make here. So Dr. Pradeep, Dr. Anshu?
Yeah, I think the point here is that actually, because we are not able to see that this thing on the CT angio, which is very unusual for a carotid web.
Correct.
And did you do the carotid duplex ultrasound also?
Yes, a carotid Doppler ultrasound didn't pick up anything.
Didn't pick up anything. And I think what Dr. Jayanta is also saying is that normally if you have a symptomatic carotid web, then I think the treatment of choice, if a patient is still symptomatic, is a carotid stenting is a good option, because what the literature review of the literature really says that that angioplasty or stenting is better than medical management, because the rate of recurrence is less.
Right.
And so I think that is a very important point. And I think it's very unusual that the CT angio was not able to pick it up. So he's right. Actually, this could be a dissection. This could be a dissection.
So just to
Good
add,
evening, sir. Dr. Vineet this side.
Okay,
Am
Vineet
I
ji.
audible?
Yeah,
Am I
you're
audible?
very much audible.
Sir, there has been some issues with the case. So actually, we did not give anticoagulation. So this patient was admitted with double antiplatelets. We gave him double antiplatelets, and while he was in hospital, he had TIAs. On one day, he had 3 TIAs. So then I was called, and we did a DSA, and we found that it is a web there. So what we did was, we, instead of giving anticoagulation, probably Nishant has mistaken it to be another case, we have stented this case. We have put in a C-guard stent, and the patient immediately stopped having any TIAs. And you're very right that the differential diagnosis of a carotid web is a dissection flap, and it's very rare, and it's a cross-sectional diagnosis. Actually, carotid web is a cross-sectional diagnosis. It's not a DSA diagnosis. But we were surprised to know, like we discussed with our radiology colleagues as well, because I was having doubts that he is having carotid web on a cross-sectional CT angio. But the radiology colleagues were saying that it is not a web, and we diagnosed it on DSA, and usually the location is typical, which was here as well. It's almost at the bifurcation, and if you see the image, he doesn't have a video static image. He has only videos. So there is a scaffolding there where there is stasis. So we did stent this, and he has been doing very well. So I'm not sure like why the CT angio did not pick. And usually, if I make a diagnosis of carotid web, even if we do just the DSA, we go back to a cross-sectional CT angio to make it because it's a cross-sectional. It's not a DSA diagnosis. It's a cross-sectional diagnosis. You need to have a scaffolding on CT angio, which our radiology colleagues did not agree. But I did find a scaffolding in the cross-sectional CT angio as well.
Okay. Do you have any runs of the post-angioplasty runs?
I think Sir Nishant probably hasn't brought them with this. So, but there was. So I remember this case very vividly. We put in a C-guard stent, which is a double-layer stent, and there was as soon as we put in the stent, gradually this thing got walled off from the main circulation. And there was still some stasis, but it got walled off from the main circulation, and the patient stopped having. We usually do a DSA or so to see the stent, but he hasn't follow up. But he find time over phone. It's been almost 5 months since we have done it.
Right. So yeah, I think stenting was a right decision, because they do well after stenting if not responding to medical management. So
Exactly. So that's one thing that on recurrence of carotid web on anticoagulation and antiplatelet is close to 25 to 36%.
right.
So
Yeah.
which is quite high, and on stenting is the mainstay of treatment. And surprisingly, I'm very happy that we are discussing about stenting. Surprisingly, my patients, whenever they have gone, they have been stenting. So that's the usual thing that I've been saying. So unlike what you used to think, we are finding carotid webs quite commonly, and it's been almost now 8 cases. I'm writing a case series and a review of literature on carotid webs. Now we have 8 cases. The sign is that if the patient has a recurrent stroke in the same vascular territory, like it was in the last case, I attended the last part of it on the which we diagnosed as PFO. So as Dr. Jayantaras was rightly saying, if you are having stroke in the same vascular territory, it is the vessel which is at fault and not the heart.
Correct.
So that's the rule that we follow. That vessel has to be at fault, and it's not the heart most of the times. And what we always go for DSA, and gradually we are diagnosing more and more webs, and some of them are on anticoagulation because of reasons that they did not want to undergo stenting, and 3 of them are on anticoagulation, and they have been doing well as well. 2 of them have been stented, and they are doing as well as well.
Yeah, I agree, because CT angio sometimes encounter some technical difficulties, especially injecting the dye and the timing and a lot of other technical factors. So we might not get a very good CT angio all the time. So DSA should be gold standard in investigating young stroke patients who are suspecting some vascular disease somewhere.
Completely agree. Completely.
Okay. All right. So I think it's a very interesting case, and I'm surprised to see how many carotid waves you are picking up. So that's really interesting. I do see maybe 1 case in 2 years, and you got 8 cases.
Yeah.
Yeah, so we'll be publishing it soon. We are having the write-up, and one of the lady was having strokes in Guwahati, and like I'll discuss it here. She was the mother of our gastroenterology resident, and she was having same stereotypical symptoms like this young man, and she was worked up extensively in Guwahati, and everything was normal. And I told her, your mother has a carotid web. Bring her here. We'll do a DSA. So we brought her here, we did the DSA, we found the web. So now I'm so certain about carotid webs, which is like, I do agree, which was very rare, and like I'm surprised, even I am surprised to find so many webs.
Waves are chasing you. Okay. So Dr. Pradeep, Dr.
Yeah, Jayant, it's a very prototypical case. As the rule of the thumb is when the same territory is affected recurrently, as in the previous case which I was telling, the vessel is the culprit. You have to look for the vessel to identify, is there a factor there? Same thing has happened here also. And carotid webs, even though we see not very commonly, but they should be considered in young strokes, same vascular territory, beautifully responding to stenting.
And Dr. Pradeep, you are being the expert in the duplex. I mean, how do you pick up? What is the pickup rate of carotid wave when you do?
We have picked up quite a lot. It is not that we cannot pick it up.
Right.
It's not that we cannot pick it up. It is we might have missed that. Maybe if not many we have seen. If we have seen around 20-25 cases of carotid web for the last so many years, we would have picked up at least 13-14.
Right.
So how do you differentiate from a like a plaque? Like how do you differentiate on a Doppler? Like is any specific?
No. See, here the web it's a very discrete one. It is the thickness, everything, and the echo texture. With all these things, we can find out.
Is it more in the B mode? It's more.
Yeah, that's right.
Right.
Yeah.
Excellent. Is there any question from the audience?
No, sir, there are no questions from the audience.
Okay. All right. So is there any other points or we like to conclude?
Yeah,
I think
with your
it's
with your
already 9:30,
permission.
we can,
Yeah.
it's already 9:30. I think we can.
Okay. So, as usual, sir, this workshop was truly amazing. And I would like to announce the impressive online view count for tonight. It's 425.
Oh,
And
wonderful.
Wonderful.
and our audience must have derived immense benefits from this. Actually, it has been appreciated by more than 20 doctors in the comment section, but though there were no questions. And I would like to thank everyone for sparing some time from your busy schedules, especially on this weekend evening. And I would like to thank and congratulate Dr. Dishan sir, Dr. Vinit sir, Dr. Swaleha ma'am for their interesting case presentations. A special thanks to Dr. Pradeep sir, Dr. Rodgi sir, Dr. Roy sir for their expert comments and valuable practical insights. Working under your guidance in future programs would be absolute privilege, sir. And apologies for some technical issues today. We will definitely work on this. And with these closing remarks, we bring this session to an end. Once again, thank you, everyone. I wish you a very delightful weekend ahead. Good night.
Good
Thank you.
night. Good night. Good night.
Good night.
Thank you, everyone. Good night.
Thank
Good
you. Bye.